So welcome everybody. Today we have Dr. Shiva Shankar, who is the Vice President of Equitable Health Systems and Innovation at the American Medical Association and an Assistant Professor of Psychiatry at the Boston University School of Medicine. He is here to share with us a little bit about health equity, and in addition, a little more about him is he is also has a passion for patient safety and serves as a PI of a quality improvement initiative to enhance screening and transfer processes for patients seeking substance detoxification. So he's doing many amazing things around the United States. And so he is here to share with us about his talk entitled Advancing Racial Justice and Equity Through Quality and Safety, 5 Key Drivers. And I will let him go ahead and start sharing with us about that. After he is done sharing, you're free to ask any questions.
Thanks, Whitney. So yeah, and if folks can get on screen, that's helpful to me. I know that you may be eating lunch or even in your pajamas. That's okay. If you're comfortable getting on screen. If you're not, that's okay too. It just helps me to be able to see faces to know who I'm talking to, and yeah, just a little bit more context about me. So I'm a psychiatrist by trade, medical director for quality, safety, and equity at Brigham and Women's Hospital. And then as of January, took on a role as vice president of Equitable Health Systems and Innovation at the AMA. And the body of work that I'm going to be talking about is work that we have tested and established as a new model for how do we operationalize equity in healthcare. We tested that at Brigham Health with the Institute for Healthcare Improvement over 18 months, and it's been a powerful model that has since spread to New York City health and hospitals, and that we're amplifying in various ways. So I'm going to share a little bit about that work that I'm bringing to the AMA, and this is, in a way, future work. This is a direction we're moving in. And since we're a small group, if we want to go around and do some quick introductions, that'd be great too. So if we're comfortable with that, so I'll let you, maybe I'll just hand it off to Meredith, since I can see you, Meredith, and then we can go from there.
Sounds good. Thank you. Hi, everyone. My name is Meredith Friedberg. I am the Field Student Recruitment Manager at the AMA. So I represent Region 2, Region 3, which is Texas, and Region 5, and then also California and Arizona. So if you guys have any questions about membership, what the AMA does, or how we can help you, feel free to let me know, and I can put my email in the chat.
I'll go next. I'm the other half of the field recruiting team. My name is Emily Ferran, and I represent the regions and the states that Meredith does not. So warm in some of your comfy cozies, and hopefully finding ways to cope with the weather y'all are having. And I'll actually pass it over to someone on our team, Kathleen.
Yeah, I work with Emily and Meredith. I'm running our medical student outreach program for the AMA. Really happy to be here today. Whitney, thank you for setting this up. And sorry to all you folks with that crazy weather you're experiencing. I know you were hoping for a large turnout today, but I think the recording will be really valuable to those who couldn't make it. So thank you for having us.
Okay, so the other folks might be in the car, or who knows. So I'll go ahead and just get started, and I'm going to keep it kind of brief, maybe 30 minutes is what we talked about, and you can pause me at any point with any questions, and then we'll have some time for questions at the end. So let me see if I can share my screen. Can we see that? Okay, so you know, as I mentioned, the focus of what I'll be talking about today is how do we operationalize equity using our quality, safety technologies, infrastructure, et cetera. And I'll just start us off with a case example. This is an actual case at the Brigham and Women's. And by the way, I'm actually in Boston, working virtually at the AMA. So, but it is cold here too. So 53-year-old English-speaking African-American gentleman, undomiciled, so doesn't have stable housing. He's Mass Health, has been a patient of ours for many years, and re-engaged with care in 2019. Usual chronic medical issues, always described as pleasant, engaged with treatment. and actually had been able to make a bunch of visits despite not having stable housing or transportation. But he did have one no-show in December of 2019 because he got confused about the date, and then had a second no-show that actually wasn't his fault. It was the transportation company, but he did ask to see the PCP before she left for vacation. And he was actually referred for termination. So I'm not sure how this works in your system, but in a lot of systems, we dismiss or terminate patients either for no-shows or for behavioral reasons if they're perceived to be a threat to providers or staff. And I know I'm not giving a ton of information, but that's really all the relevant information. So any initial questions? And we will come back to this case.
So he was being terminated based on his 2 no-shows?
Yep.
Okay.
And what that's historically meant at the Brigham is when they're terminated, is that they can never come back to care. So if they are terminated at the provider or clinic or department or hospital level or even the system level, that means they can never come back at that level. And if it's a primary care provider, because a lot of care depends on having primary care services first to do specialty care, for example, that might mean that effectively they're being terminated from the entire system. So in this case, it was a primary care termination, which means any specialty services might also be impacted.
And is that extreme? 2 no-shows? Is that a typical cutoff?
Good question. We'll come back to that. And the question would be, do you know what's happening in your systems around this? So, we'll circle back. And the reason I'm presenting this case is it highlights the model and the approach in terms of how we can more systematically identify inequities and then actually develop solutions around them. But I'm going to start by kind of revisiting the past. You know, how have we been approaching equity previously, and where do we need to move to? So the past has really been characterized by ambivalence about reform, and the future, I think, is urgent, informed, thoughtful action. The past has been a lot of euphemisms, you know, saying race-based instead of just being explicit and saying racism or sexism. It's been a lot of passive academic descriptions, meaning we really don't need more scientific articles outlining disparities in a descriptive way. We need actual action supported by resources and infrastructure, because we know there's inequities across the board, across every health outcome and across every non-health outcome. And so we really need to move from just describing the problem to actually doing something about it. There's been a lot of rationalization by good intention. So he or she didn't mean it that way, or that policy wasn't intended to have that impact, as opposed to having a comprehensive approach with consideration for systems, performance, behavioral contributors, leading to actual systems level improvement. And generally, there's a lack of accountability in this space. There's no metrics around equity at the moment for quality, safety, or otherwise. And so until we've developed those metrics, we need to actively embrace equity as a core mission of the work. I'll say the same thing in a different way now. So what do we do usually in this space is we will, as an institution, hire a couple people of color, give them a DE&I title, we'll under-resource them. We'll then tell them to solve the problems of racism and discrimination in the organization, problems they didn't create and don't benefit from. And then we're surprised when that approach doesn't work. And that's how we've been doing it. And it's a siloed, fragmented approach. And so the future really is, how do we embed equity into the fabric of the organization, into the DNA, into the quality and cost control work? And that's really what this is about. And so the model that I'm describing here is a new paradigm for quality and safety. And that's when I say I'm bringing it to the AMA, what I mean is we're seeking to take this model we've tested now with a lot of success and to anchor it at the national level and have it connected to healthcare organizations across the country. And it makes sense. There's a natural alignment when we think about quality, safety, equity. First being that equity is fundamental to quality. So another way to say that is there's no such thing as high quality and equitable care. And yet what we consistently deliver in this country is highly inequitable care, i.e. we deliver high quality care to a sliver of the population, usually those with resources, leaving out a lot of folks. And so we're not really delivering high quality care. So equity is defined is part of the definition of quality, but it's been the forgotten dimension. We've done a lot of work in every other domain, but not really in equity. And so that really takes us now to what's the approach here. And so there's other ways that this is aligned. So as I mentioned, safety and equity are both fundamental to quality. They're both focused on systems level redesign. So when we think about how medical errors happen in hospitals or how harm happens, there's often individual contributions to that, but more often than not, there's a system component, meaning we haven't designed a system that's resilient enough and reliable enough to around the individuals to ensure the best possible outcome. And so an example might be a stop sign. We use this commonly as an example in safety. A stop sign works if the person sees the stop sign, if there's no branch in front of the stop sign, if the brakes work. There's a lot of things that have to happen for that stop sign to work. And so it's not a reliable and resilient solution. But in some countries, like in Europe, when you approach the intersection, there will actually be blocks that come out of the road. So you literally can't pass through and hit a pedestrian. That's a more resilient system, because if the person falls asleep at the wheel, they're still gonna not hurt anybody else, right? So that's the approach that we take when we're talking about just culture. We're talking about how do we balance individual accountability with systems level focus. Same principles apply when we talk about equity, right? Because, so let me define equity. When I say equity, I mean pervasive, systematic, unjust, preventable differences in outcomes. And we see that across race, gender, and other factors. So those inequities are not being generated by individual bad actors. They're being generated largely by structures, systems, policies, laws embedded in 400 plus years of history and culture around that. And so it's structural in nature, and the solutions need to be structural. In both instances, there's cognitive biases. So when we think about safety, there's anchoring biases. When we think about equity, we think about implicit biases, but both are subconscious, both lead to unintentional harm. And then both require psychological safety. So it's hard enough if you're a physician or another provider, when an error has happened, to transparently examine that and reflect on it individually or as a team. Now imagine adding in the layer of a concern for bias or discrimination. It requires that much more safety. And so the point here is that rather than creating a whole nother wheel, we're taking all of that, the wheel that already exists, all that structure and technology and knowledge that we have, and now just enhancing it with an equity lens. And so that leads us to this approach, which we've been developing. And it really begins with integrating equity into everything we do, but starting with quality, safety, risk analyses. So anytime a patient safety event has happened, or a patient complaint, or an HR complaint, applying what I would call an equity-informed, high reliability lens to be systematic in identifying and addressing those risks, building into the education around it, building it into our data approaches, engaging leaders, and then thinking about organizational accountability. So I'll just give an example of each. So this is deep and complex work, but it doesn't have to start in a complex way. It can start as simply as asking, with every single risk that we're examining, is there an inequity contributing to that risk? And if so, at what level? Is it implicit, interpersonal, institutional, or structural? And then doing that in an identity conscious way. So how we used to analyze events at the Brigham and Women's, and how we do it, analyze events in most of the country, is like this. 60-year-old woman has trouble getting her medication at the pharmacy. But compare that to this version, which is 60-year-old non-English speaking woman from the DR with poor vision has trouble getting her medication at the pharmacy. So the first version is the colorblind identity blind version. That's how we operate in healthcare. We take demographics out a lot of the times because we think we're being less biased that way, but we actually can't even get to the right root causes. It's a totally different story, right? The second version is pointing to totally different contributors that would otherwise be completely missed and unaddressed. And so in terms of, what the work looks like, in the year before I joined, we had 0 action items out of all of the hundreds of safety events related to equity. And in the year after, we had over 200, and many of those did lead to system level improvements. And so the point here is that this is a journey, and progress looks like things getting worse before they get better. Another way to put it is we're dealing with a complex trauma. When we talk about structural racism and discrimination in this country, it's a complex collective trauma. And the first step is actually opening up that trauma. And that means kind of like pus coming out of a wound, things are going to get worse initially. Things are going to be messier and more confusing initially. And that's actually what progress looks like. It's more discomfort, not less. It's more complexity, not less. And so that's an important kind of level setting in doing this work. Folks are oftentimes trying to jump right to a solution or expecting an easy way to wrap up the problem, but these are problems that have been going on for 400 years. We're not going to wrap it up today or tomorrow, but we need to start the journey. And so this approach, which I'm calling the equity-informed high reliability approach, we can spread that. And other words for it are just culture. That's probably what you've heard. But or maybe root cause analysis. So when I say collaborative case review, what I'm really talking about is a root cause analysis. That's the language we use. It's bringing people together involved around an event to understand what happened, to identify the root causes, to then develop next steps. And that equity-informed high reliability approach can be spread from safety to experience to human resources to security and mortality review and residents and many other areas. And that's what we've done with a lot of success. And now it's a common way of approaching risk across the organization. And when I say we've built it into our processes, I can share more later, but it's everything from building it into our algorithms for analyzing events, our high reliability algorithms, to our trackers with demographic data, to the education that we do. And so we've built, for example, case simulations around this. We've trained our risk managers, our safety managers, our HR business partners, our patient family representatives around this approach of systematically examining equity as part of their work. And what's powerful about this approach is, I can share all the data in the world about inequities, and that probably won't persuade you. We know that data by itself is not very persuasive. It in fact shuts people down. But if I can tell you one story about one patient, like that one I just described, who's been harmed, and we can apply this robust approach to understanding the contributors, that's a powerful way of building interest and buy-in, of shifting the culture, of anchoring the knowledge and the learning. And so the data then becomes a sort of secondary but important support of the story. And so there's a lot that I can share here. I'm just going to breeze through this for the sake of time, but it's everything from just starting to collect the right stratified data to how we're standardizing it, to are we centralizing that data? Oftentimes as healthcare, we look at data in a fragmented way across the organization, to the quality of the data that we're collecting. And so we've done work in all those spaces. Another thing that's really powerful about this model is we can then present those safety cases to our board. So we've taken these individual cases, we've applied our high reliability analysis, we've identified the contributors at the system, performance, behavioral level, and then we present that to the quality board, and it's a way of activating them and engaging them and then starting to bring accountability that way. And that's a really important part of the model. And then finally, what I'll say is just about accountability is this is really starting to think about things like metrics. And as I mentioned, there's really no meaningful quality, safety, equity metrics out there. And the metrics we do tend to focus on tend to be here around things like downstream clinical measures like hemoglobin A1C. And so I'm going to just briefly share why I think that's the wrong approach. So the first reason why it's problematic, I'll keep using Brigham as an example. And by the way, when I say Brigham, I'm really talking about all of our rich, affluent AMCs. So this could be University of Chicago. This could be, your school in Texas. But let's use Brigham as an example. So if we were to incentivize, let's say, improving hemoglobin A1C for patients of color or Black patients in our population, what ends up happening? Well, the Brigham, as I'll show you right here, chronically underserves our patients of color, our non-English speaking patients, our Medicaid patients. Why? Because we make contracting decisions that make it difficult for those patients to access care. We don't necessarily design our environments to be welcoming to patients of diversity. We don't have diversity in our staff, so patients may not come for that reason. And so for many reasons, we're underserving those patients. So as an affluent AMC, we can throw a lot of resources at a small group of patients who are also already self-selecting into the population. So they're already probably doing better than the patients going to safety net hospitals. We can throw a lot of resources at them and make that hemoglobin A1C look a little bit better. But then right next door, our sister hospital, like Boston Medical Center, who takes care of the vast majority of these patients, is under-resourced, might actually struggle, and they're going to be looking like they're doing worse. They have less resources to throw at a greater number of patients. And so an incentive like that, a metric like that, which is well-intentioned, can on a larger level actually make things worse. It can actually increase disparities between institutions. Well, what's another way that this is problematic? This is an example from Tom Sequest, who leads the quality, safety, equity work at Mass General Brigham, and he's an equity person, and he uses this example himself as to highlight how hard this work is. So he developed an initiative to improve hemoglobin A1C in surrounding communities, and after a year or two, they looked at the data, and what they found was that neighborhoods like Newton, which are very rich and affluent and white, did better. They actually improved. But neighborhoods like Chelsea and Dorchester, which are historically poorer and more people of color, it didn't get better, or it even got worse. But why is that? Even when you're trying to do the right thing, there's this sort of like healthy worker effect that happens, meaning people with resources are the ones who are going to be more likely to take advantage of whatever's being offered. And so if you're really in survival mode, you don't have time to like check your email or talk to that navigator that's being offered. And so what you naturally see is this separation between the folks who have and the folks who have not. And so even with an initiative designed with equity in mind, you can make things worse. So the argument I'm actually making is, why don't we start with core measures that we have control over as institutions and responsibility over? Measures like access. Can patients even access your care? If they can't even access your care, then you're not equitable in delivering care. You're not delivering high quality care to your population. And the terminations is an example on the other end of, are we kicking out our patients at higher rates? If patients can access your care, then are they being offered services in an equitable way? So this is the CHF example is a real example from Brigham and Women's, where there was a study that was done that found if you present with heart failure and you're Black, you're more likely to get referred to medicine. And if you're white, you're more likely to get referred to the specialty cardiology service. So even when you're in the door, are we then making inequitable decisions in how you are being offered services? If you're doing 1 and 2 well, then absolutely, let's then think about number 3. But if you just start with number 3, you're probably going to have unintended consequences around number 1 and number 2, because we could, put money into an initiative on a downstream clinical measure and still make contracting decisions that systematically discriminate and keep patients out of care. And then number 4 is community. Ultimately, we need to do all these in parallel, but there's a sequence here. And that article at the bottom, I can share more articles as an example. That article really describes this framework in more detail. And I don't know if anyone's seen this, the Loan Institute rankings, but you're probably familiar with US News and World Report, which as far as I'm concerned is not a really great ranking system for capturing the quality of care delivered, or certainly doesn't really capture equity. What's interesting about this new ranking system that came out is they actually incorporate equity, and they have these 3 categories. You can see that Brigham did poorly. You can check out your institution and see how you did. What I would say is that the richer, more affluent AMCs tend to score high on quality and tend to be the lowest scoring on civic leadership. And I would actually once again say that if you're not doing well in civic leadership, you're not doing well in quality. There is no such thing. But the point is that we're moving in this direction, and this is the right direction. Are you taking care of your patients and your population should be question number 1. So coming back to the example of the case, what would normally happen? Normally, this patient would just be terminated or dismissed. And this is, I guarantee you, happening in your system right now. If you're not sure about it, you can ask and see what's going on. But I would bet my my house on it that it's probably happening in your system. And how this process is powerful is that it was interrupted. So because we've been socializing this work, it got filed as a safety report, and we've built into our reporting system, RL Solutions, a checkbox for bias or discrimination. So when they check that box, it automatically triggers an equity review by experts. Every single event is analyzed with an equity lens now, but this is an additional review that's done. And what was also important was how it was done, meaning it wasn't me or another DE&I person that asked for something to be done. It was actually our executive patient safety director and our associate CMO, because they have taken this on as their work. They see this as their work. And so they became interested and concerned. They asked for stratified data, and this is the data that we got. And you can see that we found we're terminating our patients of color at 3 to 4 times the rate of our white patients. Now, does this mean that our providers are sitting around saying, how can we systematically keep our Black and other patients out of the system? Probably not. But as with this example, because of our long history of racism in this country and the legacy there and other forms of structural discrimination, it's our poor patients, our patients of color, our non-English speaking patients who are going to be less likely to have childcare, less likely to have transportation, which might lead to no-shows. How we perceive threat is also determined by what we look like. So our decision that someone's unsafe versus safe there might be implicit bias there. And what I would say is that even in sharing this data transparently is an example of moving in the right direction, because once again, your institutions are probably dismissing patients. You probably haven't looked at the data, and you're probably not yet sharing it transparently. And we need to get to that level of transparency if we're going to change. And so on the one hand, we might be thinking, wow, Brigham and Women's is really failing. On the other hand, I would say every institution in this country is probably failing in many of these ways. And starting to share those failures as a way of thinking about improvement is a first step. So applying this system lens, we then analyzed the contributors. It's led to a very large initiative. And what we actually found was that in addition to like the 700 something dismissals that we knew about or terminations we knew about, there were actually over 1,000 more plus happening outside of our awareness. They were just being done as a procedural thing in Epic. And we found that there was no clear process or policy around it across the system. It was a local decision by clinics. There was no clear way of tracking it. And so we've had to do a lot of work now to build a process to better track it, to develop a more equitable policy. We're going to be engaging the quality board. And so this is an example to me of what improvement looks like. It's using a single instance, a single case to identify a theme, to then redesign the system in a way that works better for everyone. And I think that's another important point is, when you design a system that is robust and resilient enough that it works for the most disadvantaged patient, you can be sure it's going to really work well for our privileged, affluent patients as well. Meaning, when you improve things for the folks that are worst off, you inevitably make things better for everybody. And I'll just leave us with this quote here, which I like. We need to get better about taking care of the patients who need it the most. So kind of key takeaways here. It's taken us 40, 50 years in safety to move from the left to the right side. In our equity journey, we're still 40 years ago. It's still stigmatized and we're still uncomfortable and we still resort to individual blame. And so really we need to start shifting toward this new way of being more proactive and transparent and curious and thinking about system level improvements. So I'm going to pause there. I could share 2, 4, 5 more hours worth of stuff, but I want to leave some time for questions.
I'll ask a question first. I think, hearing about all of this and how, embedded in the system it is, what are ways that, medical students and residents can help move us to this side of more acceptance and destigmatization? What are things that we can do? Sometimes it feels as medical students we can't do a lot because we're not at the level of faculty. We're not at a level that can exert as much influence sometimes.
Yeah, so that's, I think, one of the powerful things about this approach, which is so you can start filing safety reports, whether your quality and safety department is using this approach yet or not. You can start to file safety reports and mention in the comments that you have concerns for equity. It will force them to think about it and start applying that lens. And that's a way to initiate a structured review of a problem that where you're the reporter, but ultimately it's the system then trying to address it. Because it's peer protected and because there's a lot of precautions around, protecting reporters and making sure that folks are comfortable and safe to report and there's no bullying, it should be a relatively safe mechanism. Now, what I would say is there's still fear around that, right? There's still concern about, like, am I going to have retaliation, et cetera? That will probably always be there. And I'm not going to promise that every system does a perfect job in protecting reporters, but they should be. And so it does take courage to step up and to name and identify inequities or any harm that you're seeing. But that's one way you can start to exert influence and hopefully get to a system level solution, because that's what safety and quality is about.
Are you working with other other organizations to kind of share your learnings and educate on the processes that you're sort of uncovering? And is that something that could be a tool for medical students to take into their institutions?
Yeah, so I mentioned IHI, Institute for Healthcare Improvement, and so we have, like, I'm a faculty on an 18-month initiative pursuing equity with 24 healthcare organizations, where we're um, working around shared frameworks and specific pillars. And this work, that I just described, informs a lot of what you'll see coming out of IHI and their safety work. And so we're amplifying it there. We have a collaborative going with 14 big healthcare institutions that we're bringing over to the AMA. And really where all of this is heading is toward establishing a national program that essentially is going to hopefully redefine what quality safety is about, i.e. that it's not quality and safety, it's quality, safety, and equity. And that's everything from education to providing grants for institutions to do quality equity improvement work, to maybe a national grand rounds around racial justice and equity, to funding faculty across the country, like medical directors for quality, safety, and equity, that would be partnering around the shared model. So a lot of work, and it also includes things like policy and metrics and data and dashboards. And so it's a big body of work. And so hopefully in the next 6 to 12 months, you'll see some stuff start to come out about that.
What would you say are some tangible ways that medical students, and I'm thinking specifically of M1s and M2s that are maybe still in the classroom, to get involved in some of this research or in some of the things that you've been speaking about?
Oh gosh, that's a good question. I actually might turn it back to Whitney or Meredith or Kathleen, because we've had some really powerful partnerships with students working through, I want to say, the Federation. This is where my being new to the AMA, folks on this call probably know more about the AMA at this point than I do in some ways, in terms of the structure with the federations and all the associated groups. But with the student group, they were instrumental, is my understanding, is they were instrumental in passing the 3 anti-racism resolutions that the AMA released, and that we're now going to be trying to build out further in terms of more concrete steps. And so that's one way. And then certainly, as we start to unfold this work over time, there's going to be lots of opportunities to get connected to it and participate. But yeah, have folks on the call been involved in that type of way?
I think like you said, a great way for the M1s and M2s is working with the policy. It's a way to become more familiar where you may not be in the hospitals, you may not be encountering it personally, but you're able to learn, you're still able to make a change and push for some differences. And we've had some really amazing policy come out of the medical student section, really bringing forth new ideas, new change, and kind of shaking it up a little bit. So
Yeah, and I would not appreciate the role and importance of all of you, meaning you're the next generation of physicians, and in many ways, the younger generation of physicians gets the work more than the current and older generations. And so in a lot of ways, we need to, like some of us, I'm now counting myself in the older generation, need to fade out to make space for your voice and your vision. And so I think it's a good practice to get into at this stage of starting to advocate for these issues. I kind of see it as there's two big things that we're facing as a species. One is climate change, which is going to determine if we get to continue living on this planet as a species. And the other is social justice, which is really, are we going to thrive as a species on this planet? And so connecting that to your work, healthcare has really been about delivering healthcare services for too long. It needs to really be about improving the health of people. And that's really about social justice. So our work really isn't just about doctoring, it's about improving health for people and communities. And so embracing that and taking on that role even at this stage I think is going to be important. We need your voice.
I had a question. Hi, my name is Adrian. I'm a medical student at Texas Tech. You kind of mentioned about a new equity-informed, highly reliable process, which is kind of what you referred to as this like system to review and analyze patients, really in order to like help them fall through the cracks. I was wondering, like, how does that actually work? Is there like a checklist? Is that an automated process, or is there like a review board?
Yeah, let me share a couple of slides to just, it won't get into all the detail, but I can share a little bit. So let's see here. Can you see that?
Yes.
So this is an example of the high reliability algorithm that we use at Brigham and Women's, and you might use a different one, but you can see here it's like walking folks through risk and analyzing risk. So, does the organization fully see and understand risks, and what's the system design? Is the system effective? Is it resilient? What are the factors? This is just one of 2 pages. So we have a pretty detailed algorithm. So what we did was we started very simply. We just started embedding equity into that language, and then teaching our risk managers and others about what that actually means. Like, what's the framework? How do you actually apply that lens? And so step 1 is really just giving the groundwork, the framework, building it into everything and anything. And then we started building it into RL solutions. So you can see here, if you wanted to file a safety event at Brigham, you'd see these different options. And rather than creating like a separate box, what we did was we actually added it into every single box. And so whether it's an airway management or a fall, this option will pop up. Is there a concern for bias or discrimination? And it's kind of yes, no, and you can put some comments in, and then that will automatically trigger, for example, me and some other folks to then review the event with the risk managers. Like I said, every risk manager is applying this equity-informed lens now, and they can also flag cases as well. And this is true also for patient complaints. So it's coming from both providers, but also from patients. And then we started incorporating it into our tracking. So before, we didn't have any demographics. And so I've taken out some of the information for confidentiality, but all this demographic information wasn't being collected. So now when a person enters their information, like the patient's information here, it automatically pulls the demographic information into the report. And then we track that. And then with every single event, we have specific steps that we're taking. And so the steps can vary. It could be anything from there's nothing here to we need a follow-up conversation to, we need a really extensive review, a quality review to, let's pull folks together for a collaborative case review. Or it might go to different groups. You know, it needs to go to our care committee or our quality board or other like higher level groups. And so the process is variable, it's case dependent, but ultimately what's consistent across all of them is that every single case is reviewed with that high reliability framework. We're always looking for system, performance, behavior, contributors, and then we're really trying to get to system level solutions. And this is an example of like a tip sheet we created for our facilitators, so our risk managers. If you're doing a root cause analysis and you've never like facilitated a conversation where discrimination is part of it, you might be in unfamiliar territory. So what are some simple things you can do to start creating safety in these dialogues to get to like meaningful, substantive things? I won't get into the data, but that's just a simple example. I don't know if that answered your question.
Yeah, it actually seems like you had like a whole PowerPoint ready for that, ready to go. In summary, I guess for the data, has that been shown to lead to some pretty positive results? It sounds like it.
In terms of like actual actions or results?
Right, yeah.
Yeah, so I'll share one more slide then. Or unless I took it out, I may have taken it out. Yeah, I deleted it for this talk. Okay. Oh wait, no, here it is.
Yeah, it sounds like a lot of the work that you guys do is very similar to what Partners in Health does, at least with equitable distribution of care. So it's really interesting.
Yeah, so these are just a few case examples, but I could probably give you like 50. So simple example, an individual report around a termination leading to a systems level process improvement around terminations, everything from the policy to updating how it's tracked in Epic to collecting data. A safety report around language. So the pharmacy was printing off scripts in different languages and we didn't have the technology right. So it was printing some kind of inaccurate information depending on the language. Filed as a safety report, ended up leading to a review that identified other risks like the lack of bilingual staff. So that review then led to increasing our bilingual staff and actually changing the software and improving the software. We had a report around low vision patients not getting their information in a larger font. That review then led to us discovering that, for example, in medical records, they literally could not print in a bigger font. And so that was like a system level problem that even if we want to do the right thing, we can't. So then working to enhance those systems. We've had a flurry of reports across transgender health. Everything from patients being denied reimbursement because of a diagnosis of gender dysphoria to being misgendered in registration. So that theme has led to a large initiative. Essentially, it's going to lead to hopefully developing a center, but everything from redesigning registration and signage to building an interdisciplinary service. In data, we've done a lot of work to integrate it into our dashboards, and I can share examples and articles with the group after. In terms of COVID-19, this was a great kind of pressure test of the work. And what we found was that where a lot of institutions may not have even known about inequities, we had in essence real-time monitoring of inequities through this mechanism, where in real time we could identify inequities, connect it to incident command, elevate it, and then respond very quickly. And so PPE access is a good example. We got safety reports that our transport staff, our environmental services, our food services workers, our lower income frontline workers were being denied PPE by clinical staff early in the pandemic. And so that led to a review and a change of the policy very quickly to universalize PPE access. And then other examples, everything from like with the surge, all of a sudden we saw a much more diverse population, more non-English speaking patients, realized we didn't have the capacity. It led to us then implementing iPads on the units for both safe interpretation and more interpretation. And then other examples, anti-discriminatory visitor policies, equitable ICU ventilator access, even doing work across sectors with the ACLU in terms of, for example, if an outbreak happens in the local prison and we're already at capacity, that's going to overflow to us. And we know there's injustice impacting folks in the prison system. So working outside of sectors to improve health for populations. And I can just give you plenty. I'm not even going to go through all this, but these are some of the articles I'm happy to share. I'm not sharing this to like self-promote, but rather to say, I think this is a model that's getting traction because it makes sense. And I think it is a new paradigm, and I'm happy to share any of these articles. It's everything from the work we did to address inequities in crisis standards of care, to data, to even like the portraits we have on the walls. So. Seven minutes left. We don't have to use all the time. So was this helpful?
I think it was very helpful. I think a lot of the students, want to learn about this. Is a big focus for us, especially it was at the last AMA House of Delegates meeting, just kind of inequities in healthcare. And so I think this will be really beneficial for our students to have as well, recorded and be able to see. And so I thank you a lot for letting us all be able to listen. And I'm hoping everybody is staying safe and warm, whoever is in the South right now, Texas, Alabama, some of those states.
Well, thank you all. And yeah, this is just one body of work that we're doing right now in the Center for Health Equity at the AMA. And that's, I didn't really even speak to all the other amazing work that's happening across policy and innovation and other work streams. So you just got a little sample of some work to come, but really glad to connect with you. And if there's questions, I'm happy to share articles or other materials.
I'm just curious, one quick question just for my own curious mind is, how did you connect the dots? How did you end up at the Center for Health Equity? How did you come to this role with the AMA, out of curiosity?
Yeah, I mean, in transparency, I wasn't seeking it out. So Aletha Maybank, who was the first Chief Health Equity Officer for the AMA in, I think it was July 19, has been building up the center. She heard me give a talk at IHI, I think, and then reached out to me. So I wasn't necessarily seeking out the role, but I think it provided, we'd done a lot of work at the institutional level, and it provided now an opportunity to elevate the work more broadly. And so that was one of the many appeals for me. But yeah, I didn't expect to end up at the AMA per se. And to be clear, and the AMA is moving toward more transparency around this, even with the resolutions that were passed, is the AMA does not have a great history of being on the right side of social justice historically. In fact, we've pretty much been on the wrong side for most of history. And so I think what we're seeing is a pivot in terms of the AMA's priorities and recognition that this is the work that needs to be done. And so, bringing folks like me on is a step toward that.
Thank you. Fascinating talk, by the way. Thank you.
Sure.
If there's no other questions, I'll go ahead and stop the recording.